increased from 33% to 41%. Meaning that also it's essential to scale up the availability of life-saving emergency obstetric neonatal care services, and then requiring also investing in the training and skills of those performing C-sections or those handling obstetric complications. And then in this respect, also we know that the unmet need for family planning is 17%, which is equivalent to 60 million women of reproductive age. So by investing in family planning, we can prevent maternal deaths and also prevent, let's say, the maternal deaths due to abortion and other complications as well. Most of the life-threatening complications during pregnancy are preventable and treatable, and the technology, as I mentioned, have been available. Technologies and techniques have been available, and the medicines have been available for over 70 years, and then they're not expensive. And then I mentioned about the main cause of maternal death: epidemic hemorrhage, 41%, eclampsia, hypertensive disorders, 27%, sepsis, infection, 8%, and abortion increased to 10%. I mentioned about the main causes of the complications, and then also about the importance of investing in the lady health workers program, in midwifery programs. They are close to communities and can increase awareness about family planning, about life-saving emergency obstetric care services, and the importance of skill-based attendance at base. Also globally, if you look globally, midwives, in spite of the fact that maternal mortality rates in many parts of the globe world are high, midwives account for less than 10% of the global health workforce. Investing in midwives facilitates positive birth experience and safe and effective comprehensive abortion services, improves family planning services, improves health outcomes, augments labor supply, favors inclusive and equitable growth, facilitates economic stabilization, and can have a positive microeconomic impact. So, and then also we know that the global recommendations to improve midwifery workforce and to achieve their full potential include investments in workforce planning, management, and regulation, and improve in the work environment. High quality education and training of midwives, midwifery-led strategy development, improvements to service delivery, investment in midwifery leadership and governance, including creating senior midwife positions, strengthening institutional capacity for midwives to drive health and policy advancement. And this BSc midwifery program is one of the first steps towards investment in midwifery leadership and governance, career path as well, and also in due time, hopefully, a master's degree program as well for midwives to further grow in their career path and motivate them. It would be kind of motivation, inspiration for them. Investment in midwives brings multitude returns, which support sustainable economic growth and progress towards other sustainable development goals. And WHO, World Health Organization, have identified 5 key resulting benefits. Investing in midwives leads to better health outcomes by reducing maternal and neonatal deaths and stillbirths, improved labor supply and level of economic activity, and improved supply of midwives contributes to increased economic activity. Macroeconomic impact of spending on healthcare and healthcare workers produces significant multipliers across the rest of the economy. Investing in midwives provides an opportunity to increase women's employment and the availability of decent work. If we see that, for example, according to one of the estimates, there are different estimates. One of the estimates that there are Pakistan is 44,000 midwives, available 16,000, and the gap is 28,000. And then now we know that the female labor force participation is close to 22%. Even by only training 28,000, we can increase the female labor force participation significantly. It is all the economic benefit investing in midwifery because we provide, we increase the female labor force participation and also improve the health outcomes. Both can contribute. It's a kind of economic contribution and also contribution to improvement to strengthening the health services. We have several success stories from the Asia Pacific. For instance, nearly 1,005 public health facilities in Cambodia offer comprehensive services with at least one midwife at each facility. Outreach activities are carried out in hard-to-reach locations with essential medicines, equipment, materials being provided to health facilities. Cambodia's maternal mortality ratio dropped from 488 deaths per 100,000 live births in 2000, just 22 years ago, to 160 in 2070, just because in targeted investments, including making the public health midwifery service available. Key policy and program interventions resulting in this significant drop from 488 to 160 include improving the quality of care, investment in education by midwives, and then midwifery-led care as well. So just I'm finishing. So let's, ladies and gentlemen, let me conclude to conclude that in line with the above national and international commitments I mentioned, especially the FP20 Family Planning 2030 commitments, SPD 25 commitments. To conclude in line with the above, with the mentioned commitments, Pakistan needs to urgently invest in the significant increase in increasing the number and quality of health workforce, especially religious health workers and midwives, who are trained as per the global standards, the standards of the International Confederation of Midwives, ensuring universal access to reproductive health commodities and services, including family planning commodities, to increase family planning uptake, contraceptive prevalence rate to 50% by 2025 and 60% by 2030, after the national commitments, ensuring uninterrupted contraceptive community for both Department of Health and Population Welfare departments, increasing national capacity for emergency preparedness and mainstreaming of the minimum initial service package in disaster risk reduction, and especially implementing. It's key to invest in the implementation of the midwifery strategy. This is essential, one of the key pillars for reducing maternal mortality. Thank you very much.
Thank you very much, Dr. Bakhtiar.
We have been joined by one of the great friends for HSA, Dr. Mahipala Palitha. I'll request him to come up here and join us. He had a meeting with Qatar Embassy, so the moment he was free, he straight came here. And I'll request my student and my faculty to give him a standing ovation, because he has been one of the main support for Health Services Academy. So,
Thank you very much, Dr. Palitha Mahipala, who's WHO country representative.
You know why Pakistan did so much good in COVID? One reason was Mahipala Palitha. He was in Pakistan, along with other development partners.
He is very active and very hardworking, and thank you very much for joining us over here. Now I'll move to our next presentation. Our next honorable guest, Professor Dr. Fareed Midhat, who is a public health expert and a recognized leader in population and health, family planning, and safe mother in Pakistan and abroad. He has extensive experience in designing, managing, monitoring, and evaluating large-scale projects and writing the project's proposals. Currently, he is heading the department and is the faculty of RMNCH at Health Services Academy. Professor Dr. Fareed, please.
Thank you very much, Samina. I will be very brief because, I think the morning has been very active and busy. The topic I will talk about is partnership approach in to advance the MNCH outcomes in Pakistan. And I think there's something which we have all felt very closely, that, most of our colleagues, myself included, we have worked with development partners, international, bilateral, and international donors, So what is actually partnership? Partnership is actually now is increasingly becoming a very popular and effective at the global level. We know that, the Gavi, for example, and the Global Fund for AIDS, Tuberculosis, Malaria, these are international partnerships, and we are familiar with them. At the national level, unfortunately, although we have been working with international partners since the inception, since the independence of this country, I think very few people probably know that UNICEF was actually established for the war, the Second World War, and it was about to be wrapped up when Pakistan was in the beginning, the first year of Pakistan. So Pakistan was among the countries who insisted in the, United Nations to keep the UNICEF going for the developing countries. And basically, since then, I think the international agencies, WHO and UNFPA, UNICEF have been working with in Pakistan. Similarly, USAID and similarly, DFID. Unfortunately, and this is something which I usually start with something controversial, as you all know, we have not been able to use those resources and that support very well. So, for example, we actually come up with their agendas. Like, it's not that their agendas different or there are any, but I think that the way in other countries, for example, it happens is that the national governments and the national professional alliances actually lead the way. They are in the driving seat and not the other way around. There was only one exception, I think, during 2015, 2018 in Punjab province, where the top political leadership was very, very committed. And they had a very clear roadmap. I actually consider that is one example where, the development partners can be, worked with, not necessarily the other way around. So I have an experience of working throughout my life, but I would like to, mention something which we did 2012 to 2018 in 16 districts of Sindh. And that was a partnership with other national and international NGOs also. It was supported by USAID, and it was called the Maternal and Child Health Integrated Program, MCHIP, as it was famously known. What we actually did that in the beginning, we had some issues working with the Sindh government, but within a few months, actually, we developed so close relationships that we were working within the government, not outside the government. And it was as if we were part of the government as we were in the service delivery sector. We were also working with the private sector, but in the public sector, we definitely working very closely, like PPHI, and we had the PPHI which runs the BHUs and civil dispensaries in Sindh. We were very closely working with them as if they were on the same team, so there was really no difference between the two teams. So I think that kind of partnership leads to some success, and we were successful. After 5 years, there was a third-party evaluation, and we were able to achieve our goals very successfully. How actually partnership evolves, that's where I learned. There are 3 stages actually. You start with coordination. Coordination is simply the synchronization of activities. So you work with the government and you say, okay, you will be doing the same, thing which we are, but we'll be supporting you, in a very peripheral way. Or you can stop doing something which we will be doing because we have this money and, we would like to spend it because, we have to show the donors our burn rate, Nabila knows what I'm saying, right? And the second stage, of course, is cooperation. So cooperation is more like an integrated planning. I think that's where you actually work very closely. You start before actually starting your intervention, the development partner and the receiving end government should sit together and plan the whole thing. And the last, the highest stage is the collaboration, where there's a pooling of resources, where there's a common goal and common agenda, where the difference between the development partner and the developing country actually ceases to exist. And I believe that we did achieve that kind of level in MCHIP during our last couple of years. It's unfortunately, Pakistan government has not been in charge, and it doesn't steer the partnerships well towards what should the government actually do? They should identify the gaps and they should steer the partnership towards the predefined goals and priorities. The predefined goals and priorities should come from the government. They're actually there. There was an exercise some time ago. We did that. We developed a matrix of what areas were missing, to identify. For example, we did not have any midwives, at that time, and we did not have family planning services available to the large rural populations of Balochistan and Sindh. So we developed that matrix and shared it with our development partners and requested them should basically sign on where they want to focus. It didn't really work that well because of like a lot of complications. But I think that's what the government should actually do. The government must guide the donors and the development partners both together, and it should not be the other way around. Unfortunately, in Pakistan, it is sometimes, in the current situation, for example, there's a post-flood MCH crisis. We all know about that. Millions, hundreds of thousands of women actually are delivering in very, very, bad circumstances. They don't have any access to health facilities. Okay, so this should be the top priority at this time, and we should not forget that the first thing we should focus on is to restoration of the services and normalcy in the flood affected areas. So we should probably first focus on there, and besides that, I think the donors and the development partners should together work for sustainability, not necessarily just bringing in innovative kind of I have heard this word a lot before, a magic bullet is coming and some extremely good innovation is coming because it worked in Rwanda. But let me assure you that what worked in Rwanda is not going to work in Pakistan. This is our experience, that we have to stick to what we have. For example, we have a successful program, Lady Health Focus Program. This was probably the only public sector government supported program which remained successful a very long time and actually achieved its goals. But now it's it's not as it was starting at the starting stages. We have another example, which was the community midwives. This is an excellent idea to bring the services closer to the rural women, But unfortunately, for various reasons, it hasn't worked very well because the CMWs who are trained, majority of them, I can say that they are not actually practicing. So, and this is this happened during the 1980s also, when Pakistan trained close to 55,000 traditional birth attendants as trained midwives, or skilled midwives, but it also didn't work at that time. So similar to that, I think this is something. So what we need to do today is we need to focus on equitable distribution of resources, improvement of the quality, and we should not unnecessarily go for innovations or experimentations. We should basically focus on what system we have, how can we strengthen that system, how can we make that system work and work better, and this should be the goal of the partnerships. I think stability and sustainability and resilience, these three things should be our goal. Thank you very much.
Thank you very much, Professor Fareed Midhat. And before I make the announcements, I request our guest of honor, Surgeon General Nigar, to come at front with Dr. Shahzad and Dr. Palitha so that we can give shields. And Dr. Bakhtiar, please step forward to give shields to our speakers for today. Please join us. It's quite exciting. Chai bhi milegi. Thank you very much, Professor Dr. Zohra, for Professor Dr. Now I request to give shield to Professor Dr. Fareed Midhat. I'll request Dr. Shahzad to give shield to our guest, Dr. Palitha Mahipala. Dr. Fareed Midhat, your shield is waiting for you. जी Now I request Dr. Shazad to give a shield to Dr. Bakhtiar Parev. Now I request Dr. Shazad to give shield to our guest of honor, Surgeon General Nigar Johar Khan. Please a big hand for. I'll request Dr. Shabina Raza, Dr. Nabila Ali, Dr. Babar Sheikh, Dr. Mubashir, and Dr. Tariq to join us for a group photo, please. And Dr. Tabinda Zaman, who is actually the force behind Professor Dr. Shahzad Ali Khan. हर आदमी के पीछे एक कामयाब औरत का हाथ होता है और कामयाब औरत उनको भी कामयाब बनाने में किरदार अदा करती है. Thank you very much everyone. Thank you very much for being patient and thank you for joining us for today. Before we leave, I request our honorable guests to proceed for the inauguration of Public Health Law Department, first ever in Pakistan. I would request to join us for tea, but before we go, I would like to pass on my gratitude to everyone who came here today to become part of this monumental occasion and request our guests to move towards refreshments. Thank you very much.
बड़ी टेंशन की इसकी आप नहीं सोच सकते फोन यार ਤੁਹਾਡਾ ਇੱਥੇ ਉਹ ਸਰਚ ਕਰਵਾਇਆ ਨਹੀਂ ਗਿਆ ਤੇ ਨਹੀਂ ਚੱਲ ਰਿਹਾ ਹੋ ਗਿਆ ਖੁਦਾ ਦਾ ਨਾਮ ਨੇ ਬੜੀ ਦੇਰ ਹੋ ਗਿਆ ਹੁਣ ਮੈਂ ਆਇਆ 5-10 ਮਿੰਟ ਹੋਏ
ਜਦੋਂ ਦੀ ਮੀਟਿੰਗ ਸਟਾਰਟ ਹੋਈ ਉਸ ਵਕਤ ਦਾ ਉਹ ਮੁੰਡਾ ਇੱਥੇ ਮੇਰੇ ਕੋਲ ਉਦੋਂ ਮੈਂ ਕਮਰਿਆਂ ਦੇ ਵਿੱਚ
ਨਹੀਂ ਨਾ ਉੱਥੇ ਨਹੀਂ ਚੱਲ ਰਿਹਾ ਸੀ ਮੈਂ ਹੁਣ ਆਇਆ ਥੋੜੀ ਦੇਰ
ਹੁਣ 2 ਮਿੰਟ ਹੋਏ ਮੈਂ ਦੱਸ ਕੇ ਗਿਆ
चला गया
कह रहा ऑन कर रहा हूं
ये वो देखो टीवी पे आ रही है स्क्रीन हैं चल चल चेक कर
रूम से नहीं
हाँ रूम में
उसके बाद ब्रेक
क्या नाम है आजम भाई ये स्क्रीन चेक कर उसके बाद ब्रेक होगी
लैपटॉप वो लगा के प्रेजेंटेशन सुन लगा
अब देखने चल रही है
अब चल रही है
आ गया ना बस
यार वो वाईफाई डिस्कनेक्ट होता है ना तो वो चला मेरी बात नहीं प्रेजेंटेशन देनी है अभी वो लैपटॉप लेके
नहीं ऑन अभी रखे अभी नेक्स्ट प्लेनरी स्टार्ट हो नहीं कोई इशू नहीं है
एक इधर भी चलती
यार यार
ब्रो मैं अभी बोल रहा कमरे सारे रेडी हैं
कमरे स्विच करें दूसरे पे बस ठीक है
एक या दो ਇਹਨੂੰ ਤਾਂ ਫਿਲਹਾਲ ਆਨ ਕਰ ਆਇਆ ਹਾਂ ਵੇਟ ਪਾ ਲੈ ਜਿਹੜਾ ਜ਼ਰੂਰਤ ਨਹੀਂ ਆਪਣਾ ਕਾਲ ਦਾ ਫੋਟੋ ਲੈ ਆਉਣਾ
बहुत अच्छा वो पर ये तक चाहिए क्या
ਉਹਨਾਂ ਦਾ ਕਹਿਣਾ
ये कितनी देर से ब्रेक हुई
ਬਹੁਤ ਸੈਸ਼ਨ
बस ही ना ब्रेक के बाद एक्सरसाइज शुरू हुई ना
कैमरा मसला बनाना चाहता
सर कैमरा
बंद भी था
कैमरा ऑन
कैमरा चेक करें
तो सारा चीज एक चीज चेक करते ठीक है देखो जा चेक
वो ऊपर नहीं चल आ तो चाप फिर आ नहीं दे
कैमरा बंद करिए
हाले भी हमें गांड दी है बस काटे टेक वाले ओके ये आई है जी जी सर छोड़ दे नहीं
वही खत्म कर रहे हैं इसीलिए अभी खत्म हुआ है ना तो चेक कर रहा हूँ ब्राइटनेस चेक जाओ
पहले कार
नहीं
नहीं
पहुंच नहीं लेनी कसम में पहुंच
ओ देखो
सर वही कर रहे हैं
स्टेज तो
चौथे जी पंजे की
कर देना ना डाइस से
टेबल चेंज करी पक्की दे करो ब्राइटनेस थोड़ी और चाहता हूँ
ये चलेगा अभी ये ठीक है ये चलना है उसके बाद फिर बाकी 3 आवर्स में हो जाएंगे ये लाइव जाओ ये देखिए कोई आया इसको एडमिट करना है ये सारा डे 1 का ही है ये डे 1 शाम को कितने बजे तक तकरीबन चलेगा
चलो आ जाओ यार
ये देख वो ये तकरीबन रात को कितने बजे तक चलेगा
ये रात तक चलेगा 7-8 बजे
7-8 चलिए 7-8 ठीक है कैमरा ही बंद कर देते हैं
क्यों
पता नहीं अभी
ये एलईडी बंद है कैमरा नहीं बंद
नहीं ये देखना
यही लगा के रखें इसमें हमारा कैमरा बंद हो गया
वो पूरा डिस्प्ले करे ना उसकी तो चले डाटा का
नहीं नहीं मुश्किल मैं तो कुछ मुश्किल नहीं
आप ज्यादा टेंशन हम लोगों की हाँ
नहीं मैंने अभी एडमिट किया कुछ लोगों को एक अरूसा मंसूर DGPPW
हाँ ये दूसरा लखानी है
और फरीदा और नाइला यास्मीन
ये तो कोई और अच्छा ठीक है
फरीदा तो वही है ना जिसकी वीडियो है
बस
और वो जो आपकी वो कैथरीन थी वो चली गई है
चलेगी
क्या बता ये 5 ये नाइला यास्मीन ने ये नफी की
इनको मैसेज कर दें कि क्वेश्चन 11:15 पे स्टार्ट होते हैं 11:15 पे
अरे रब्बा कान दर्द कर रही हो।
लैपटॉप का डेस्कटॉप दिखाएं ये पूरा ऑन हो चुका है।
ठीक जा रहे हैं?
शुक्र अल्लाह
मिनिमाइज करें एक दफा डेस्कटॉप दिखाएं।
ये मिनिमाइज नहीं होगा। ये
डेस्कटॉप थोड़ी देर रहने देना।
रहने दो।
हाँ वो तब पता चलेगा ना कि वो सेट करवा
सेट करें ना इसको।
बस वो ऐसे ही करेंगे
और क्या
बंदा होनी तो टर्न हो गया।
हाँ क्या
पहले तो आया चार में दे फिर मेरे मेहमान आए मैं तो है चल पानी दो मुंडे गए शायद इस बार लगी अच्छा उन्हें दो इन्हें शराब पीती है फिर तो मैं जनाब तेरी मैं मां तेरी
ये वैसे बोल ही नहीं
हाँ हाँ मैं रोज आना यार मिलता बड़े अदब देना
ये इसका आया सुना नहीं अच्छा इधर भी चलती है ना भाई बाहर नहीं गुड मैं उसे कुछ इशारा
मुझे जब पता चला ना शराब पिए अच्छा पानी दिए अंदर जाने चाय के लिए बोतल चुके मैं इधर आते चंद बोतल शराब पी लेते हैं मैं सटन लगा था तो छीन आ गया हम ले जाने वो फिर नहीं सब कमरे में नहीं शोएब ने विजय को अक्षर अक्षर वो ले गए मैं को ना दस सकती मैंने ना दे यार नहीं किया
ठीक है नहीं
पकड़
कर लें
मेरी बढ़ जाएगी सारी
कर लें IT
जाओ जाओ 50 11-15 पे सेशन होगा स्टार्ट और
मैं
जाओ जाओ हाँ
नहीं मैं ब्रॉड कर रहा था मैं
अली जो मैंने बताया वही है, जो मैंने बताया वही।
इसके पीछे बैकड्रॉप किया जाए। हाँ ये जरा अच्छा है, ठीक है मैम।
कैथरीन की प्रेजेंटेशन नहीं है, कैथरीन की वीडियो
ऑनलाइन वीडियो
ऑनलाइन ही भेजी। इधर रुके रुके सबर सबर सबर, ये दो हैं, कैथरीन की और फरीदा।
बस
फायदा है फरीदा, फरीदा, इन दोनों की प्रेजेंटेशन वो वीडियोस। उन्होंने कहा जी हम प्रेजेंट नहीं करेंगे, अब हमारी वीडियो चला दें।
रिकॉर्डेड है ना, अगर इनका कोई चाहिए आपको मैं ईमेल भी फॉलो करूँ।
ये आ गई मेरे पास, आ गई पी लिया चाय शाम आपने पी लिया?
सही होगी स्क्रीन।
चलो यार बहुत पहुंच लिए
फुल बेहतरीन सब्जी।
जरूरत तो ठोस हो जाती।
मैंने जाके देखा था वाईफाई
अभी ठीक आ रहा है,
वो सप्लेटर उधर जाके मैंने एलसीडी लगाई और दोनों पे चल गया।
अभी ठीक आ रहा है घंटे से। जब तो हम हुआ ना वो नहीं चला।
वो एलसीडी लगाई है मैंने, वहां पे चल गया सप्लेटर वो भाई।
मैं कुछ नहीं था, कुछ नहीं।
स्टार्ट है स्टार्ट करते हैं।
हाँ वो जो पहला नंबर है उसकी ऑनलाइन सेक्शन में, ऑनलाइन मतलब सॉरी वीडियोस रिकॉर्डेड प्री रिकॉर्डेड वीडियो यार जिनके सेशन में वो आते हैं यार कैमरास ऑन करें, कैमरास ऑन करें, कैमरास ऑन करें जी। वो चल रहा है, चल रहा है, चल रहा है, सच चल रहा है।
वो वाला कैमरा वाला झटका मारता है एकदम, उसको समझाया मेरा मारता है कि वहाँ पे बहुत सारे कैमरा मैन नहीं सर, सारे
नहीं मैं बता
सारे मीडिया वाले
जब वो जो ऐसे नहीं नहीं ये जब इसमें मोड़ रहे थे ना,
हाँ।
तो मोड़ते हैं ना जब, तो वो ऐसे करके उन्होंने, मैंने फिर कहा भी था कान में जाके, मैंने बॉस थोड़ा सा ना स्मूथ कर ले।
मैं कह देता
तो कोई इधर जो देख रहा होता है ना उसकी आंखें फिर जानी है। अच्छा है, फिर वो अनप्रोफेशनल लगता है थोड़ा सा। ये हुई ना बात, अब उनको नजर आ रहा होगा। ओ तकी, ओ तकी, मध्य प्रदेश में मुख्यमंत्री बैठे, मध्य प्रदेश में मुख्यमंत्री बैठे,
उत्तर प्रदेश
ऐसे लोग काठमांडू में पाए जाते हैं, पतले पतले। उस दिन ना वेस्ट कोट पा के आया ना, वेस्ट कोट इस मतलब वेस्ट कोट जिस बंदे के शोल्डर बॉडी से थोड़े बड़े होते हैं तो वेस्ट कोट उसको अच्छा लगता है। दूसरा ये है कि आप अगर पतले हो तो थोड़ा सा उसको बंद करके पहनो ना, मतलब ऐसा रखो। इस वेस्ट कोट पा लेता है अपना इसी से, वो तू विकास ही तो चलू के बैठी। मैं ऐसे कहा, मेरा तो कोई मजाक नहीं है, स्कूल में रहेंगे ऐसे काम कर रहे थे, बस ये और बंद भी बच गया है इसमें पूरा नहीं बचना रैप कर लेंगे एंड बिल्कुल आया। मगर तू कितने आ रहे हैं तो मध्य प्रदेश में मुख्यमंत्री बन गए, मेरे मुंह से तो साफा निकल गया है। साथ वाला था ना उसने इसमें चेड़ लगा दी, पर ये भी यूं मैं कहा यार कोई बंदा मुंह से स्माइल ही नया ना बट्टा ही बन गया तू।
जो मटेरियल आ रहा है सेपरेट करके
hope कि मेरी आवाज सब तक सही पहुंच रही है. So please, I'll request you to take your seats, and I'll start requesting our guests to join us on the stage while we wait for our chief guest.
ओ भैंस टोला हो गया.
Bismillahirrahmanirrahim. I'll start by introducing the theme of the plenary today. So the theme of plenary is linked to our overall conference theme, which is about sexual and reproductive health and bringing the research to action. And this is in context of the UHC and in the context of the SDGs, which Pakistan has committed to achieving. So I will request everyone to please settle down. The theme for our plenary session is midwifery services and education in lower and middle income countries. For this session, we have the honor of having with us as the guests of honor, Dr. Nabila Ali, who is the head of JSI. I will request Dr. Nabila to please join us on the stage. Thank you.
अभी ये मैंने प्ले करके रखी हुई है, ठीक है.
अब वो जो कहेंगी ना
मैं करके ये और साथ ही अभी
I will now request the other Dr. Nabila, like Dr. Nabila Ali said, A to Z. So Dr. Nabila Zaka, she will be representing UNICEF, and I request her to join us on the head table. Thank you, Dr. Nabila. Dr. Atya Abru from the Ministry of National Health Services, Regulation and Coordination. She has been looking after the RMNCH and the midwifery services for a very long time in the Ministry of Health. And I will request her to join us on the stage. Dr. Azra Ehsan, who has traveled specially from Karachi to join us for this conference. Dr. Azra does not require any introduction. She is well known as a leading obstetrician and a gynecologist. She has led the SOGP, Society of Obstetrics and Gynecology in Pakistan. She currently is also working as an advisor for the NMCH, National Committee on Maternal, Newborn and Child Health. Dr. Azra, thank you very much for joining us. And my last guest is Professor Zohra. She is the Dean, Allied Nursing Department in the Fatma Jinnah Medical University. She has traveled from Lahore to join us for this conference. Dr. Zohra is also the head of the Obstetrics and Gynecology Department. Thank you, Dr. Zohra. I hope I have not missed anyone. We also have with us two panelists who will be speaking on the midwifery services and education in lower middle income. They're seated right in front of the head table, Dr. Ghulam Nabi Qazi, who's a leading public health specialist. And with him is Ms. Fawzia Mustaq, who's the registrar of the Pakistan Nursing Council. I will now go online. We have our panelists include who will be doing some presentations. They have joined us online, and they had plans to travel to Pakistan because of the political. Just introduce them first, and then we can start with their presentations. We have online with us Ms. Catherine Breen Kamkong. She's the regional advisor SRHR with UNFPA. And she will be talking about maternal and neonatal health, role of midwifery and regional perspectives. We also have with us Ms. Farida Begum. She is a program analyst with the midwifery program of Bangladesh. She will share experiences with midwifery services in Bangladesh. We have Ms. Arusa Lakhani. She is the President, Midwifery Association, Pakistan. She also could not travel because of the political things happening here, but she will join us from Karachi online. We also have as a panelist, Dr. Sher Shah Sayed, who is the President, Pakistan National Forum for Women Health. And he will talk about the role of midwives in maternal morbidity and mortality. We thought to start because we have the online participants and we had given them an earlier time. We hope to have Dr. Shazia Sobia Shastro as our chief guest. She's the Parliamentary Secretary for Health and the President of Pakistan Nursing Council. So as she joins us, we will invite her to the head table. And in the meanwhile, we'll start with the online presentations. If we have the online participants with us, maybe they can introduce themselves. I'll start with Ms. Catherine Breen-Kamkong.
Yes, a very good morning, or it's maybe afternoon to all the participants there. I'm very honored to have been invited to give the presentation today, and just sad that I can't be with you in person, but just to make sure that things go smoothly, I've recorded the presentation so that you can hear it in case of internet problems. So thank you very much, Dr. Mariam. Over.
वॉइस नहीं आ रही उसकी कैथरीन की आवाज नहीं आ रही उसको बोलें उसका माइक म्यूट है कैथरीन का हाँ मैंने अनम्यूट की रिक्वेस्ट कर दी है उसको
So we've been doing the online thing since COVID started, and it's been 2 years, and every time there's a glitch. No matter how many internet IP and connections we get, we always have this problem. My apologies for that. The speakers are online, but this time we cannot hear them.
Yes, hello everyone. I'm not sure, can you hear me now? But my name is Catherine Breen-Kamkong, and I'm the UNFPA Asia Pacific Regional Office Technical Advisor on Sexual and Reproductive Health. And it's I'm very grateful for the invitation to present today, and sorry that I cannot be with you there in person. I'm not sure you can hear me clearly, so we've actually recorded the presentation so that you can play it. So with that, I'm going to finish.
Hi, Catherine. I can hear you so well.
You can
But I think
देखिए वो हेयर कर रही है हमें तो जो डॉट नाइला का मैसेज है वो कैन हियर
लेटर ओके कह रहे मेरा अनम्यूट है अब सिस्टम में मसला है मुझे बाकी पार्टिसिपेंट सुन रहे हैं
Hi, Catherine. Can you hear me?
Yes, I can hear you well.
I guess we all can. We both can hear
We
each
can
other.
hear each other. Yes, I'm
But I guess
sorry.
somehow they are not able to hear us.
Yes.
फिर बंद कर दिया उसने
I think if you can hear us, then
Catherine, we can hear you now. Thank you.
okay, Dr. Mariam, great. Yes, so a very warm greeting to everyone there in the regional conference. I'm very grateful for the invitation to be part of the conference. I wish I was there in person, but I cannot be. So I'm happy to share the recording of my presentation, and I will be here for questions. My name is Catherine Breen-Kamkong, and I'm the Sexual and Reproductive Health and Rights Technical Advisor for UNFPA in our Asia Pacific Regional Office. And Pakistan is one of the countries that I work with very closely over the last many years on midwifery, amongst other things. So thank you for the invitation over from me. And I think you can play the presentation that's recorded, Dr. Mariam. Over.
Thank you, Catherine. We'll go to your presentation now. Thank you.
Assalamu alaikum, and very good day to everybody there in the meeting. I'm very sorry not to be able to be with you in person, but it's a great honor and pleasure to be able to have a little time in your meeting today to discuss how midwives save lives. My name is Catherine Breen-Kamkong, and I'm the
Sexual and Reproductive Health and Rights Technical Advisor for UNFPA in our Asia Pacific Regional Office. So I just wanted to put a little bit of context before talking about midwifery in our region. And very, very sadly in our region, maternal mortality remains a very real and significant threat to women's lives. We have 10 women dying every hour in pregnancy and childbirth in the Asia Pacific region. And many countries will need to double or more than double their current annual rates of reduction of mortality to ensure sufficient progress towards both national targets of your own countries, but also the Global Sustainable Development Goal 3. In addition to that, absolute numbers of maternal deaths really are staggeringly huge in many countries in our region. And a call to act really is at the heart of UNFPA's mandate and many countries' own mandate and development goals. So why invest in midwives? How is this related? We now have very solid evidence that investing in professionally educated and regulated midwives promotes the health and well-being of women, of adolescents, and of newborns. And it also puts safe and effective SRMNAH care within reach of many, many more people. We also have evidence now that investing in midwifery could save millions of lives each year. It contributes to national and local economies, and it really contributes to women's empowerment and gender equality. We know that the majority of midwives are women and they look after women. So there was a very important study in the Lancet in 2021, which came out and provided us with the actual evidence on the impact of midwives in preventing and reducing maternal and neonatal mortality and also stillbirths. By 2035, we can avert 67% of maternal deaths, 64% of newborn deaths, and 65% of stillbirths. So that's going to save 4.3 million lives by the year 2035. If we're less ambitious and we have increases in midwife delivered interventions by 25%, it's still significant. And even a modest 10% increase in coverage every 5 years still gives us significant results and saves many, many lives. So scaling up care by midwives must now be a global priority. Professor Mary Renfrew also had written some very important work on this around the time of that Lancet article. Health workers do not have the full scope of midwifery competencies. They cannot provide the quality care or save the lives that international standard midwives do. And that's why it's so important that Pakistan is moving towards this commitment of having midwives educated to International Confederation of Midwives standards. Because they are integrated, when integrated into health systems, can provide skilled, knowledgeable, safe, respectful, and compassionate care for childbearing women, for newborn infants, and for families across the whole continuum from the pre-pregnancy period to the early weeks of life of a newborn. And it also includes, of course, the family planning work that midwives do. Midwives really can optimize the normal for women. They strengthen women's own capabilities. They provide interventions for women and neonates that can both prevent, but can also treat complications. And what a very important thing is that they enable timely access to multidisciplinary services for those who need them. If we have skilled, competent midwives who can stabilize women who are in critical situations with postpartum hemorrhage or preeclampsia prior to referral, we're going to save many, many lives. So the scope and quality of care can improve more than 50 health and wellbeing outcomes. reducing mortality and preterm birth, and improving maternal and newborn health and well-being. Also breastfeeding and attachment. And it's a very, very cost-effective intervention. So in 2021, we released globally, UNFPA and partners at ICM and WHO, we released a big report called The State of the World's Midwifery. We've had a number of other reports on midwifery, but this was the most, this is, as you can see on my screen, this is the most updated one that we've just recently completed in 2021. And what we found is that we have a very huge unmet need in our workforce. If we say from the evidence that midwives can deliver 90% of key SRM-NAH services, and then we find that they're only 10% of the workforce, this is really a problem for us. We know that, if you can see on the slide here, you can see that globally, only 8% were midwives. And out of the percentage of time on SRM-NAH, still only 19% of midwives, and half of those 19% are associate professionals. So they haven't completed the full training according to ICM standards, and they can't provide the full scope of practice of a midwife. So as I mentioned, midwives can provide about 90% of the care needed, but they account for less than 10% of the global workforce. There's a global shortage of about 900,000, and in our region in Asia Pacific, it's around 200,000. It may be even more because we will have lost a lot of midwives across the globe due to pressures during COVID, and also loss of life of health workers, including midwives during COVID-19. So we're going to make progress by 2030, but we still have a major shortage. So the report, it called for investment in 4 key areas, and this might be something you want to deliberate on over the coming days, and it might be of great importance also for Pakistan at the juncture that you are with midwifery. So the report calls for an investment in both quantity and quality. So we can't sacrifice one over the other. The two have to go hand in hand. So first of all, investing in high quality education is critical. We need to make sure that our educators and our trainers, that they have all of the capacity building and support needed to provide that education, because if they don't have those skills, then it's going to be very difficult to train the workforce. We also have to make sure that education and training institutions are very well regulated and managed, that we're not having too many student ratio of student midwives to the faculty. There needs to be a proper space in the skills lab. The curriculum needs to be according to ICM standards. So we have a lot of work to do in quality education, and this is the first pillar of investment that is critical for investing in midwifery. And I congratulate Pakistan for moving in this direction. The second pillar is investing in health workforce planning, management, and in the work environment. So when we were collecting this data for the workforce report, we found that health workforce data systems are very weak in many countries, and we don't have accurate data that reflects the workforce that we have. How many midwives we have, where are they working, what about nurses, what about obstetricians? We don't have that information, and if we don't have that information, it's very hard to plan. We also don't know who's retiring and when, and we don't know where they're deployed. So which parts of the country have midwives and which parts don't. So this is very important that we invest in our health workforce data systems and our workforce planning. We have to plan for normal retirement, attrition, and movement that happens. And we also have to make sure that underserved areas have midwives deployed there. So we need to look at government systems to ensure that they have positions created for midwives to be deployed in those areas. When you're working in a very busy overwhelming facility with maybe only one of you as a midwife there, it's very difficult to provide quality care. So enabling work environments are very critical also. And I mentioned effective regulatory systems. That's where we try to make sure that we're keeping our midwives licensed and we're monitoring their competency through continuing professional development linked to relicensure. So these are all areas that in the second pillar that the report recommends we invest in. And the third area is investing in midwifery leadership and governance. In some countries, we have a chief nurse, sometimes not though, and very rarely do we have a chief midwife. It's also sad sometimes that we see that we're missing midwives in other leadership positions or sitting around the table when we're doing things like, for example, maternal and perinatal death review. We need senior midwives at those tables, working together with multidisciplinary teams and contributing with all of the knowledge and experience that they have from caring for women and newborns. It's also very important that we invest in strengthening institutional capacity for midwives to drive health policy advancements. So like I mentioned, we might have those systems like maternal and perinatal death surveillance systems, but it might be our midwives are going to be really responsible for implementing the quality improvement initiatives. So they really need to have a seat at the table. We also need, the fourth area is investing in midwife-led improvements in SRM-NAH service delivery. So very important that we have good communication and good partnerships where midwives are really delivering and leading the delivery of care for normal pregnancy, normal birth, and managing those complications when they arise and working with multidisciplinary teams. There's a lot more evidence now that midwife-led models of care have very, very solid outcomes. So if we have a midwife looking after a woman during her pregnancy, during her labor, during her postnatal, and helping her with her family planning, we have much better outcomes because there's a relationship also that's built with the woman. We learned a lot during COVID-19, and it's very important that we apply those lessons learned in other times. So finally, just again, I would like to say that an investment in midwives is really an investment in life. And so I thank you for giving me the time to share a little bit of this evidence with you and for your commitment to move the agenda forward in Pakistan for ending preventable maternal and newborn mortality and stillbirths through this pathway of midwifery. And with that, thank you very much.
Thank you, Catherine. And Catherine had to cancel her travel plans just last minute. We are doing two things simultaneously. One is this conference and another is a training of the midwifery faculty, training of trainers on EMOC in PIMS. And she had planned to be here for both of them, but thank you very much for bearing with us and being online. My apologies for the late start. Our next presenter and speaker is Ms. Farida Begum. She's a program analyst in Midwifery Bangladesh. Is Ms. Farida with us online? So maybe
I think she was, but she's gone. I think.
Right. So we have a recording of her presentation. We can have that. Thank you.
In Bangladesh. I am Farida Begum, consultant, unit field, midwifery unit. Now I am going to present the previous history, what we are doing now, and the future way forward. So who is midwife? Actually, it is identified by the International Confederation of Midwives. The midwives who are regulated and educated international standards and provide 87% of essential care for women and newborn. And in Bangladesh, our Honorable Prime Minister declared in 2010 at the World Health Assembly to bring midwifery as a separate cadre, as a separate profession. So we have identified that minimum education as a 12th grade and 3 years diploma program with sexual and reproductive health and rights. This is a competency this international confederation midwives aspect. This is total coverage of ISA, quality maternal care, initial stabilization of emergencies to improve the access and quality of women, newborn, and also the adolescent, and geographical equity, client satisfaction, and this is cost effective. Now, the new midwifery profession Bangladesh, the areas we have covered: governance, education, service delivery, and advocacy through midwifery society and voice for the midwives. And if we'd like to say the governance, we have the administrative body. It was Directorate of Nursing Services, which is now, due to midwifery introduction in the country, now the Directorate General of Nursing and Midwifery. Midwifery is added in this administrative body. So in 2016, Nursing and Midwifery Act approved. Under this government body, policy for midwifery and costed action plan, job description, standard operating procedures, organogram, and career path have been developed. So standard operating procedures, it was also developed in 2016, but now it has been revised to include some medication, because midwives will work at the community level, so they have to have some capacity and some authoritative power to use some kinds of medicine where no doctors are available. And regulatory body, it was the Bangladesh Nursing Council. After 2016 introduction of midwifery, it is renamed Nursing and Midwifery Council. Again, the midwifery included in the name of Nursing Council. So under the Nursing Council leadership, we have developed accreditation, CPD, linked to the licensing. Licensing is practicing after every 5 years. So we didn't have any kinds of update knowledge or skill before re-licensing, but now we have developed the CPD on which we can provide some kinds of knowledge and skill to the midwives, and that will work for the re-licensing for the midwives. And monitoring quality, we have developed the dashboard, already it's in practicing. And professional body, in 2010, when our Prime Minister declared the midwifery profession in Bangladesh, so in that time, Midwifery Society established in 2010, led by the nursing professional. But the good things is now the 2021 election was held and all the executive bodies are midwives. This is a great achievement and milestone for the midwifery in Bangladesh, who can make voice for the profession and for the women and newborn in Bangladesh. Now, I would like to mention some education, diploma and higher education. So already I mentioned that ICE standard diploma midwifery, we are following both for public and private. We have 62 nursing institutions where the midwifery education are earning. Now we are going to revise the name of nursing institution to nursing and midwifery institution. And we have private, now it was 7, but now 105 in 2021. BHC and master's midwifery curriculum developed, and already BHC in midwifery, bachelor degree of midwifery has started in 4 nursing colleges. Although this is a new profession, but we are suffering for faculty, I mean dedicated midwifery faculty. So we have introduced the BHC in midwifery who can come out after 2 years and then they can lead the education as a dedicated midwifery faculty. So as I mentioned, we didn't have midwifery faculty. So through UNEP's support, 2 years, the SRS Master's Program, Sexual and Reproductive Health and Rights Master's Program through Dalarna University, 150 faculty already graduated, and out of 62, 53 institutions we have covered by SRS faculty. This is also a milestone for Bangladesh. And clinical science modeling we have introduced. I will discuss later on also midwifery lead care and quality midwifery lead care following the WHO standard. And already I mentioned the BHC already has started in July 2022 this year, and master's program curriculum development already in draft stage. We will start in 2024. This is another, I think, milestone. It will be a milestone for Bangladesh. And this is left-hand side, you can see the government support through UNEP advocacy. You can see the upgradation of the institution, midwifery institution. In 2013, we had 525, and now in 2022, we had 62 in the government, and private it was 7, and now 105. This is really great achievement for Bangladesh to train the midwives from 525 to now 3,500 students every year. So we have many success stories until the introduction of the midwives. We have now licensed diploma midwives 7,600, and already 205,057 deployed in the government facilities. 5,000 more posts already created, added in June last year, and from this year the deployment will start in phase-wise. And more than 400 midwives working in the humanitarian crisis, and also outside the health facilities, they are delivering, you can see the picture. They are providing the at the same time, they are working at the humanitarian areas, and they are doing the delivery in the bus, transport. When they were working at the hospital and they called and they attended the delivery in the bus. And also boat delivery, you can see the picture, and they call from the facilities and they support the women to deliver the normal vaginal delivery in the boat. And now this cyclone, the delivery done by the midwives in the cyclone center, you can see the down picture of midwives and their, delivery babies. 6 babies they deliver in the cyclone center. And many midwives are working in the private sector. And midwifery comprehensive research services I mentioned earlier, that we would like to ensure the quality of care, with significant improvement on the maternal and newborn care quality, including the skin-to-skin care, initial stabilization, delayed cord clamping, and also the midwives are also providing family planning during the delivery room. We can call the postpartum family planning. And cervical cancer screening, midwives are involved also with UNIP supported project. Another one is fistula prevention, menstrual regulation, and post-abortion care services. Also, midwives are involved with the gender-based violence prevention and as a first line responder in the healthcare setting. Along with this, midwives are working in the government, humanitarian, NGOs, and private settings.
Thank you very much. Thank you, Dr. Ms. Farida was online with us, but then she had to leave because of some other commitments, I guess. Our third presenter is Ms. Arusa Lakhani. Arusa, if you are online, would you like to present online, or should we go ahead with the video?
Assalamu alaikum and very good morning to everyone. I'm happy to be part of this conference and so humble for the invitation, and thank you for Aisha for continuously following me up. I was just thinking that to ensure that there is a smooth connection, we can play the video, and I'm here online for the further discussion.
Thank you, Arusa. So we'll play Arusa's presentation, please. Thank you.
Thank you so much. Thank you.
And very good morning. I'm Arusa Lakhani, and I'm the president of the Midwifery Association of Pakistan, and working in the Khan University as assistant professor. Today, my talk mainly revolves around the midwifery education, and it's very important for us to understand why. The evidence indicates that midwifery care, wherever it is included, has averted over 80% of all the maternal deaths, stillbirth, and neonatal death. With the proven midwifery interventions, it has improved the maternal outcomes, including a reduction in major causes of maternal death, which is hemorrhage, hypertension, and sepsis, very, very common in our country, and the leading cause too. Similarly, midwife-led continuity of care prevents preterm births by 24% and reduces neonatal sepsis. These are the midwifery intervention that this slide tells us that across the lifespan in the midwifery and childbirth, during the adolescent health, how midwives can make a difference. So when midwife works within the continuity of care, applying these interventions, it tells us that how important it is that are making difference in mother and children's life, including adolescent. And these are the outcomes that are proven that makes a difference. It says that 16% less likely to lose the baby, 19% less likely to lose the baby in the next 24 hours, 16% less likely to have an episiotomy. These are the midwifery interventions. And whenever the interventions are provided, and whenever the midwives attends the woman during her birth, the satisfaction and the experience enhanced. They liked the information and the advices and the explanation and the choices offered by the woman to the woman by the midwife. So when we talk about action plan for healthy lives and well-being, in 2018, UNFPA, UNICEF, WHO, and other global partners, they came together and developed SDG 3 action plan for healthy lives and well-being. They committed to align all the efforts with the country priorities. And they said that it needs to accelerate progress by leveraging new ways of working together. And it is very important to highlight that they also mentioned that unlocking innovative approaches and account for the contribution to progress should be transparent and engaging. So the priorities that were set during this partnership was that every woman and newborn to be cared for by a midwife. The midwife should be educated, trained according to the international standards, should be allowed to have a legal practice within their country with a full scope of work. It was also noted that midwifery leadership should be positioned at a high national level, planning and budgeting processes to improve decision making that is done to achieve universal health coverage. And we must think on this. The third point that was prioritized in that partnership is coordination and alignment, that all stakeholders globally, regionally, and at the country level should come together and join hands to ensure that midwives are working at their part in the country. The framework for the quality maternal and newborn care is very important. And this was presented by midwifery leaders across the world at the global level, where they have included the philosophy, the values, and the organization must possess to promote midwifery care. It was said that when midwives work within this framework, they ensure to provide education which is according to the standard. They screen the patient, they plan their care, they assist the mother and promote normal processes of the birth and prevent complications. And if the complication occurs, they are trained to provide first-line management and refer the case accordingly. So midwives in our country want better education, including access to higher education and development, to be empowered to take leadership, and to know their skills are valued by medical doctors, and to provide better quality of care for women and their children.
Can I request that
So to have a quality midwifery education, this is
for
the framework that is proposed.
So I'm really sorry for requesting to pause the presentation. Our chief guest, Dr. Sobia Shazia Sumro, she's the Parliamentary Secretary for Health and Pakistan Nursing Council's president. She has a prior commitment at 12:30, and she has requested that if we can take her comments first and then continue with the presentations. So, Madam, please, it's up to you. If you want to comment from there or you want to come here. Easy to me.
बिस्मिल्लाहिर्रहमानिर्रहीम एंड अस्सलाम वालेकुम। सबसे पहले तो सॉरी कि मैं थोड़ा सा लेट हो गई एक मीटिंग की वजह से। फर्स्ट ऑफ ऑल थैंक यू फॉर इनवाइटिंग मी हियर। it's a very important to learn how to improve the quality of the nurses and how to learn the midwifery's curriculum, how to improve the curriculum. Pakistan commitment to achieve the SDGs relating to health, particularly the amendment of the universal health coverage by the year 2030. Acute shortage of lopsided balance within the human resources for health in Pakistan, WHO recommendations and Pakistan requirements for human resources health. Number one, the dynasty of the least 23 doctors, nurses, and midwives per 10,000 Pakistan, with a population close to 208 million, was at the 14.5 in end of 2017. Number two, the midwifery services in Pakistan context and it's important. Number five, national vision and strategic framework.
WHO 6 building blocks, framework and action 2016 to 2025 by WHO, EMRO, and strengthening quality midwifery education jointly developed by UNFPA, WHO, and ICM. The WHO strategic directions for the nursing and midwifery, the framework for action for strengthening the midwifery education, the WHO 6 building blocks for health system, strengthening the global midwifery framework, and the findings of Midwives Want campaign. Vision of Pakistan strategy to ensure that every woman in need receives comprehensive midwifery care by skilled, well-educated, licensed, well-regulated, caring, and autonomous and the confident midwife. Professional, regardless of any consideration towards the convicted goals and of achieving universal health coverage by 2030 in Pakistan. Goals of the vision. The overall goals of the national vision is to enhance the scope of the midwifery professional in Pakistan to contribute to achieving SDGs following the WHO global strengthening directions, nursing midwifery framework, and the framework for the action to ensure quality education, services, governance, leadership, research, governmental organization, public, private sector to work in the producing midwifery leaders who can represent the governors, ensuring the independent practitioners can perform in their field with sound evidence-based knowledge and skills. New position of midwives need to be created at all levels of the health system, together with the creating a career structure for the midwives across the province to ensure the similar job descriptions and role of the responsibilities, opportunities for professional growth for the entire profession, which is lacking at present. The federal government has committed to arrange foreign faculty members for the medium-term time frame, while qualified midwifery teachers having a master's degree may be identified and given some more training of 6 months to 1 year, particularly in non-midwifery subjects required for graduate students. Based on the framework of the province will develop their own midwifery strategies, which will need to be linked and aligned with the other developments taking place in the nursing midwifery sector. In addition, the programmatic modalities, the Midwifery Association Pakistan will take the lead in advocacy events. Pakistan is currently undergoing massive shift of the regard to the education of the nursing and the midwifery education, monumental changes and rapid production of quality personnel in both fields, with an override abolition of the diploma program. Some formulas for cost sharing has been also worked out between the federal and provincial governments. The Ministry of the National Health Services Regulation and Coordination will immediately constitute a small technical working group comprising of all the stakeholders that will regularly deliberate on all the issues intensively for the period to come up with the mutually shared vision till the 31st December 2022. Even thereafter, the deliberate on implementation issues. Meanwhile, the provincial departments of the Health and Population Welfare and Health Directorate of the federally administrator will be the empowered to develop their strategies and operational frameworks specifically designed for their area's jurisdiction. A transition plan may accompany the frameworks set for the time frame 2023 to 2030. The PNC and the regulations wing of the Ministry of Health and Regulation Services will ensure uniformity
within the provinces. The role of Midwifery Association of Pakistan will be related and its scope expanded to make a truly representative professional body. The United Nations agencies, particularly the UNFPA, WHO, UNICEF, will provide the much needed technical expertise, not only at the policy making strategies development level, but in the practical implementation as well. I think this program will help us to improve the quality of nurses and midwives also. Thank you so much.
Thank you very much, Dr. Shazia. And Dr. Sobia, I'm sorry, I keep saying your name in the wrong order. So Dr. Sobia,
Dr. Shazia Sobia.
Dr. Shazia
It's
Sobia.
easy.
Right. So thank you for being with us. And I understand you have a meeting to attend. We will continue with the session and we will share the policy.
Carry on, please. Thank you.
Thank you. So if we can please have the presentation.
Post by the WHO, aligning with all the national strategic partners that says that the midwives, to ensure to have a quality education, one must act, monitor, and review the processes, gather the evidences, build public engagement and advocacy, prepare educational institution policies, settings, and clinical matters, strengthen faculty, standards, and curriculum, educate the students, monitor and evaluate the processes of the education, and then strengthen the leadership and then continue to move forward. This is one of the evidences that when midwifery education is supposed to be implemented and ensure that it is sustained in lower middle income countries, then what are the 4 or 5 steps that needs to be done? So first of all, high level commitment is required. Data and evidences are required. That includes the budget allocation to have a quality midwifery education. Sustaining quality education and supporting midwives, including appropriate remunerations. Removing barriers to access for women, including financial barriers to choose the midwifery care. And focus on quality as well as coverage to ensure respectful midwifery care. So this is the current pathway of our midwifery education in Pakistan, where we have 2 years community midwifery, 1 year diploma for those who are already registered nurses, and 2-year lady health visitor. And they all either practice midwifery, some pursue nursing, or some just doesn't pursue midwifery because there are no career paths. So the current midwifery in Pakistan has many complexities. The key area is where we have to understand is lack of consistent and uniform standards and competencies. There is undermined the ability of midwives to educate effectively for improved care for women and children. There is a professional fragmentation that limits the ability of midwives to realize their own potential through continued professional development. There is absence of higher education in our country that contributes to low acceptance and invisibility of midwives and the midwifery profession. The multiplicity of designation and the roles has contributed confusion and misperception about the competencies that the midwife possesses. And it's truly lack of acceptance of the role as a prime minister. So lately, a 2-year undergraduate degree program initiated with a vision that women's profession in Pakistan needed the model with the development of intellectual and leadership capabilities to advance the profession and benefit the larger society in general. So the higher education was initiated in 2012. And it is a 2-year program which is offered to those nurses who has 4-year diploma program taken with the institution. That is 3 years of nursing and 1 year of midwifery.
Thank you very much. Arusa, with your permission, I will briefly go to Dr. Shershah's talk. because two of our chief guests of honor have other sessions to attend, and I really do want them to go over the presentations we have. So if we can just quickly have Dr. Shershah's talk here. Thank you.
तो आपका शुक्रिया कि आपने मुझे मौका दिया कि मैं आज के इस अहम इजलास में मिडवाइफ के बारे में बात करना मुझे, क्योंकि मैं बहसियत ऑब्स्टेट्रिशियन और गायनेकोलॉजिस्ट के जो समझता हूँ कि पाकिस्तान में सबसे बड़ी मुश्किल पेश आती है, वो सब पेश आती है जब मेरे वार्ड में, मेरी क्लिनिक में मेरे पास मिडवाइफ नहीं होती। तो जब मिडवाइफ होती है तो मेरा काम बहुत आसान हो जाता है। उन्होंने जो मैंने काम किया है, आज मैं गाइडलाइन या थोड़ा बहुत सोशल में गुजारा, इससे मैंने ये देखा कि अस्पतालों में खासतौर पर मैटरनिटी यूनिट चलाने में मिडवाइफ का सबसे अहम किरदार होता है। जिस मुल्क में मिडवाइफ अच्छी होती है उस मुल्क में मैटरनल मोर्टिलिटी रेट बहुत कम होता है, उस मुल्क में डॉक्टर आराम से रहते हैं, उस मुल्क में सर्विलेंस सेक्शन कम होता है, उस मुल्क में मुतमईन माए और बच्चा बाहर से निकलते हैं। तो मिडवाइफ का बहुत ही अहम किरदार है मॉडर्न आज की ऑब्स्टेट्रिक्स गायनेकोलॉजी में। हमारे पूरी अस्पताल में मिडवाइफरी लीड यूनिट चलता है और वहाँ पर लेबर की इंचार्ज मिडवाइफ है। मिडवाइफ के मर्जी के बगैर कोई काम नहीं हो सकता है, मिडवाइफ की मर्जी के बगैर सेक्शन भी नहीं हो सकता है। डॉक्टर डिसाइड नहीं कर सकती है तब तक मिडवाइफ उसको ये नहीं बोले कि इस मरीज को कुछ मेंटल डिस्ट्रेस है या मैटरनल डिस्ट्रेस है, फिर डॉक्टर दिक्कत होती है इसका या करता है इसका सेक्शन छोड़ दीजिए। बात यह है कि अच्छी स्किल्ड एम्पावर्ड मिडवाइफ डिलीवरी की इंचार्ज हो, उसके पास टाइम होता है कि एंटीनेटल क्लिनिक में वो मरीजों के साथ बात करे, उनको समझाए, उनका कॉन्फिडेंस करे, उस पर एतमाद हो। और फिर मरीज को बोलती है कि आपको लेबर में अस्पताल आना है, और लेबर में जब मरीज पेट में होती है, मरीज के हिसाब से मरीज खुद छोड़ करता होता है कि मेरा ऑपरेशन कर दिया जाए, तो निर्धार समझाती है तो ऑपरेशन करने की जरूरत नहीं है, नॉर्मल डिलीवरी होगी। बस जिस मुल्क में नॉर्मल डिलीवरी होगी वहाँ पर मैटरनल डेथ भी कम होगी, वहाँ पर मैटरनल मोर्टिलिटी भी कम होगी, क्योंकि अच्छी मिडवाइफ 80% से ज्यादा लड़कियों की नॉर्मल डिलीवरी करा देगी। इसलिए मिडवाइफ का बहुत ज्यादा अहम रोल है। यह रोल शुरू हुआ एंटीनेटल क्लिनिक से डिलीवरी तक। अब डिलीवरी के बाद करना है, लेकिन डिलीवरी की बात करना उससे पहले मैं एक और चीजों को बताना चाहता हूँ। मिसाल के तौर पर इनका यूक्राइन खत्म है, एक औरत सोची उसका बच्चा मर है, उससे खुद से ठीक हो है।
So, Dr. Shershah comes to the point quickly, and that's a really great thing about him. Before we get some comments from our guest of honor and from our panelists, it would be an incomplete event on midwifery if we do not remember Mrs. Imtiaz Kamal and her contribution to the midwifery services in Pakistan, for establishing the profession, for being a champion for it. She passed away very recently, and I will request if we can just briefly say a dua for her. Jazakallah, and thank you very much. And thank you, Dr. Qazi, for pointing this out for the dua. I know that Dr. Nabila Ali, Dr. Nabila Zaka have to join other sessions as well. So I'll request them for their comments and then we can continue, and Dr. Athiya Abru as well. So if you have any comments, that would be great. But otherwise, your presence is very much appreciated. Thank you.
Thank you very much, Mariam. I think we are all honored to be here at Health Services Academy. I just want to share that midwifery initiative in Pakistan is one of the success stories, and we have seen a decline in maternal mortality and also, a dent in newborn care because of midwifery. Of course, family planning plays a very vital role in that. But my 2 cents, not one, but 2 cents would be that midwifery education is extremely important. But that alone cannot work. We need to have a systems approach where we are emphasizing on the quality of care for midwifery education, how to improve that, and also increasing the number of midwives. Although all the gynecologists are also midwives, but here we are talking more of community midwives, who can reach out to the communities and deliver babies where women have limited mobility, or they have financial limitations and cannot go to the private sector. So it has to be well entrenched within a systems approach where the budget allocations are looked at. The advocacy should not just be to scale up midwifery, but also to allocate adequate or the required budgets for this. On top of that, a very strong behavior change communication, strategy has to be in place, because end of the day, it is a behavior, where women go, how they seek care. Even if the, midwifery education is improved, we need to take care of the entire envelope, and work on it, on the different aspects of that. So my 2 cents are to engage and involve the planning and finance departments when we are talking about midwifery and its scaling up and, improving the quality of care. So thank you very much for addressing this very important area. Thanks.
Thank you, Dr. Nabila. Thank you very much. So over to Dr. Nabila Zata. Thank you, ma'am.
Assalamu alaikum. I think I will just say 2 things, and it's coming from the recent experience from flood emergency. And we all know that pregnancies and deliveries don't stop during emergency. So those things are there and the needs are also there. But when the rapid needs assessment findings came, it was done jointly by government and the UN agencies. There was like the bars of healthcare staff that's available in those districts. And when you see the female service providers, it's hardly visible. That bar is almost negligible. So what are we talking about? If we are creating midwives, we need physicians. If we need physicians, we need also to see where are the gaps really in geographic disparities, where are the really needs are higher. And there the issues are much more complicated. Once you don't get girls' education, you don't have qualified girls to enter into those courses, then their family support is not there. Then maybe, we haven't thought about their career structure. That's what happened with community midwifery. So all those pieces need to be really in place before we make a difference. And I would just also remind that though we are happy looking at the DHS surveys that our skilled birth attendance rate is going up, but still we have 2 million births every year in Pakistan, which are happening without a skilled birth attendant. So those 2 million births should be our target, that our midwives should be taking care of, and the system should be taking care of the midwives. Thank you.
Thank you very much, Dr. Nabila. Dr. Nabila has been working for a very long time with the humanitarian response, and not just in Pakistan, but in other countries as well. And I believe her on the face of it when she says that we don't have female providers when an emergency happens in a country like Pakistan. So that's where the importance of midwifery is highlighted, that we need to have them, not just doctors or other healthcare professionals. Dr. Athiya, if we can request your comments. Dr. Athiya has been working with the MNCH and on the midwifery services for a very long time on behalf of the Ministry of National Health Services Regulation and Coordination. Thank you.
Giving me the opportunity to be part of this important session on education of midwives in Pakistan. Much has been delivered since till now about the education and about the curriculum and about the numbers of midwives and the services which they are supposed to provide to our women of Pakistan. Back in 2017, Ministry with the support of UNFPA conducted a situation analysis of midwives, and among other things, two important areas that were identified for strengthening, and the recommendations were also given, were about improving, about enhancing the education of midwives according to the ICM standards. And the other thing was thinking about the career pathway for the midwives. And both of these areas are crucial to the policy making for reducing maternal mortality and morbidity in Pakistan. Somehow or other, there were some delays in achieving these, in working on these recommendations, but now ministry was and ministry is very much focused on improving the health of mothers in our country. And midwives, as we know, are the backbone of achieving good results for maternal health outcomes, and improving the education of midwives in the first instance, and then giving them opportunities to come forward and to get their jobs is very much important. So right now, ministry has already been working on improving and on redesigning the curriculum for midwives, and the curriculum has already been developed, and now it is under the process of endorsement by HSE and PNC. And hopefully, after this endorsement, it will be the implementation will be started. Right now, we are having the trainings of faculty for midwives going on, and all this will definitely be helping the midwives, the communities I'm talking about, community midwives, to perform their duties in a much better working environment and in a much better way. Midwifery, we all know, is also a part of nursing, and we have trained nurse midwives as well. But there is a need to strengthen the midwifery in this cadre as well, and improving the education of midwives and the chances of their flourishing is obviously pivotal to improving the health outcomes of mothers. So for reducing maternal mortality, among other aspects, midwifery education and strengthening midwifery, not only for education, but also for increasing the numbers, to increase the coverage, is also important. And ministry is very much cognizant of all this, and ministry is already working on it. And in the essential packages of health services, the interventions which are related to maternal and child health are being put on top priority, and more than 50% interventions are related to reproductive and maternal and newborn child and adolescent health. So this shows how much focus government has on improving the health of mothers and their children. So I must congratulate HSA and PNC for coming forward, for taking forward this agenda of government to enhance our midwives' education and to improve their skills and their knowledge in their field. Thank you very much, all of you, for attending this important session. And thank you very much once again, HSA, and all the organizers for letting us collect here and talk about this important issue. Thank you.
Thank you, Dr. Athiya. And Rania is very impatiently waiting for you to take you to your session. So thank you for giving us your precious time. So we also have with us two key panelists, and I will start with Madam Fawzia. She is the Registrar, Pakistan Nursing Council. She's a very long-term friend, or not just my friend, but also of Health Services Academy, and she has worked very hard for the nursing and the midwifery profession. So I will request her to really talk about the future prospects the Nursing Council has for integrating and basically regulating this midwifery profession within the existing health system stream. So over to Madam Fawzia Mushtaq, who's the Registrar Nursing Council.
We on wireless on or this on.
Thank you very much, Dr. Mariam. Wonderful presentations, and I think I will appreciate you at least the time came for realizing that midwives are important for the community. They are playing a vital role in society, in healthcare side. At the moment, Pakistan Nursing Council, because Pakistan Nursing Council have a different cadre of midwives, like community health midwives, nurse midwives, people midwives, lady health visitors. Lady health visitor is a two-year program. One year is a public health and 1 year is a midwifery. Pakistan, and now the Pakistan Nursing Council come to that point. We are merging that, and we are developing curriculum for midwives, bachelor 4-year program. We developed the curriculum, and it's already approved from the Pakistan Nursing Council, and we collaborate with the when we developing this curriculum, UNFPA and HSA will help us in this regard, and it's on the table of HEC. Inshallah, we will start this bachelor program. But now I have to point it out, here's something, because some projects came for just like community health project. They came in 2012. Now, one of the province, Punjab, they stopped this community health project. I think we can, if we can initiate any project, then we realize that this project is sustainable or this project is implemented. These two things are important for this. And thank you so much.
Thank you, Madam Fawzia. It's always, whenever I go to Nursing Council, I don't ask her for an appointment time. I just walk into her office and she makes time to talk to me and discuss the things with me. So please, a round of applause for Pakistan Nursing Council, especially Ms. Fawzia as well. I now request comments from Dr. Ghulam Nabi Qazi. He's a public health specialist. He has worked for a very long time on developing the human, sure, sir, you can come here as well. So on the developing human resource for health frameworks, networks, and he was engaged in developing the PC1 for the midwifery services, education and regulation in Pakistan. He was also a partner with us in developing the midwifery strategy for Pakistan. We do hope it is with the ministry. We do hope that it gets through and we are able to actually implement it in the country. I saw Ms. Rafia from Forum for Safe Motherhood here. I think she's left, and she was one of the other partners who worked with us on highlighting the gaps in the midwifery services and what really needs to be addressed to make the strategy really a success and make it implementable. So, Dr. Qazi, I request you for your comment. Thank
you. Thank you very much. It's always better to see who you are addressing, so I came here. Sorry for the sore throat, because there's a change of season. So first of all, I'd like to salute HSA for organizing this wonderful conference. And I'm equally grateful to the Parliamentary Secretary, Dr. Shaz Sophia. She is also heading our TB Parliamentary Caucus. So it was a pleasure to hear from her, and she also made my life easy by mentioning the essential elements of the midwifery strategy. So we are undergoing a massive paradigm shift right now. We have abolished the diploma programs in all the provinces. We are going for degree programs. As Ms. Wali told you, we are developing curricula for these, and also we are trying to upgrade the level of the schools and colleges for midwives. But there's several issues here, and I'd like to touch on some of the points mentioned by the learned speakers. It's very, very humbling to come after them. Because sorry. First of all, Catherine from UNFPA, I'm grateful for her because she mentioned that the role of investing in midwives, and this is critical for the government, for the health community, that the more we invest in midwives, the better to be for indicators. Dr. Nabila mentioned that indicators have declined, but not at the sufficient pace. We need to accelerate the pace and move forward. And also, she mentioned about the momentous declarations of the mid-90s, and I'm reminded of ICPD 1994, and we've come a long way after that. Although I mentioned the indicators are not improving at the pace we want, we are still improving a great deal since where we were in 1994. And then Farida Begum Sahiba from Bangladesh. We have lots of similarities with Bangladesh. Bangladesh is now 50 years old. And I'm glad she mentioned that the Nursing Council should be renamed the Nursing and Midwifery Council. It is the same thing we're doing in Pakistan. And also, she mentioned there are only 4 colleges for midwifery in Bangladesh. So that may be the way forward for us. We should gradually increase the number of midwifery colleges. And we have chosen the 26 public health schools producing LHVs for that purpose. And we'll be moving on with them. Also, she mentioned, then Ms. Russo's points are very, very valid. And I'm grateful to her for mentioning healthy lifestyles. Because as you know, the problems of obesity are growing. We have overweight and obesity all around us. Pardon. So, and we also have inadequate regulations surrounding tobacco control and road safety issues. So unless we link all these non-communicable diseases with maternal and child health, we will not move forward. Also, she mentioned that there should be high-level commitment. I cannot expect more. Unless we have high-level political commitment, we will not have necessary funding and resources and the coordination to carry our agenda forward. Dr. Shersha pointed out midwifery-led units. That is also very relevant, but we are a few steps short of that. national level. Hopefully will be there. He also mentioned that we should take into account the affectees, the survivors, and those who lost family members. And remember, the loss of a mother in a household can be catastrophic for the whole household. And Dr. Nabila Ali also mentioned finance, taking finance and P&D along. I cannot agree with her more. We have a PC1 ready. It has been proportioned amongst the provinces and the federal government. But unless we have the requisite financing, we cannot move ahead. So really, we have to take planning commission, the planning and development division, and the final division together with the provincial P&D and final departments and move forward. Dr. Nabila Zakka was also very pertinent, especially in the present context where we have floods and humanitarian disasters. I really apologize. Yes. So, sorry, I do. So in humanitarian disasters, you see, the need for midwifery is all the more pronounced. So we really need to have not just government-led support, but also community support and family support. And I'm grateful she mentioned career structures, because LHVs or midwives really start from grade 5 or grade 9 and really retiring grade 9s. So really there's no pathway for the professional growth or development. So I'm grateful to Fawzia, Nabila, for flagging this issue. A crucial point mentioned by Dr. Nabila is 2 million births are not attended by skilled birth attendants. And these 2 million would be the ones in the most peripheral areas. So they are the most hard to reach. And as we're going towards universal health coverage in 7 years, we need to take them on. I'm grateful to Dr. Atia Abrut for being here from the ministry. And she also pointed to career pathways and opportunities for growth and the need to strengthen the midwifery. These very relevant points. And of course, last but not least, I agree with Ms. Fawzia Mushtaq that we do not have to go for short fixes, but develop sustainable programs. I once again beg your pardon for my sore throat. Thank you very much.
Thank you, Dr. Kasi. Dr. Kasi has been a long-term partner with the Health Services Academy and with UNFPA in supporting the midwifery services and education's development. I'm very much thankful to both Professor Azra and Professor Zohra for being with us. The midwifery services, why they're important, I'll just quote one small figure for you. In Pakistan, every day, 16 or 17,000 women go into labor. So we have 16 to 17,000 deliveries every day. And among those, just 1 to 2% go into complication. And that 1 to 2% complication is directly related to the maternal mortality we have in Pakistan, which is continuously stuck at 150 plus. So if we have, so just imagine 15,000 normal deliveries, if we have really good, well-trained midwives, they can be taken care of by the obstetricians. Professor Azra, Professor Zohra would, I think, endorse this, that the OPDs are overburdened, the labor rooms are overburdened with normal deliveries, and all of them are to be attended by a doctor. So they cannot attend to the complicated or the complications in time, which leads to morbidity and mortality among the women. Dr. Azra, if I can have your comments on this, please. Thank you.
Thank you very much, Dr. Mariam. I totally endorse your comment. You know, we are clinicians. Okay. We are clinicians, me and Professor Laura. So we are actually in the battlefield. We see what is going on in our labor rooms, and our midwives are in small numbers, and those who we see are not the real midwives because they are not adequately taught and trained, and then they are not allowed to work also as midwives. So they, you know, the sad part is that the doctors work as midwives, the midwives work as nurses, the nurses work as like cleaners, and the cleaners just go and have mithai and gratification presents from the relatives. So, you know, nobody is doing their own job. And midwife is certainly misunderstood in Pakistan. I have worked in England. I have yet to see a midwife in Pakistan. The midwife in England allowed me when I could have my breakfast and if she was nice to me, if she liked me, she would give me tea and toast in the morning, and she would not wake me up all night and tell me in the morning, I have delivered her, I've done this, you had to write this order, please write it for me now and all that. And if she didn't like a colleague of mine, she would call her every 10-15 minutes during the night. And we were not allowed to enter the labor suite without her permission. Only when she invited us, we could go. And we did our jobs like research and, you know, all the other things that have to be done. And research, for that very reason, is not done in Pakistan health facility. So, you know, allowing the midwives to work and, you know, but it is also important who choose midwifery as a profession. Because the girls who join the profession, we all know Pakistan's basic education is very, very poor. You know, a lot of them don't even know how to write their names, what to, you know, learn about their profession. So their basic education is very poor. And you don't have to assume, you know, they know this, they know that. You have to teach them like a primary school student first, before you start teaching them midwifery. So, you know, we should make this profession so, you know, so attractive that, you know, girls from good educational backgrounds choose this as a profession. And like, you know, they have these career bazaars or whatever they call it, universities. That is what midwifery schools need to do. Go out to these, you know, good schools which provide good education and, you know, induct these well-educated girls into the profession who will surely become much better midwives that we are seeing just now. So it's not about midwifery education. It is much more about how they're taught in primary schools and secondary schools. That is also very important. Thank you.
Thank you, Dr. Azra. It's like I think Dr. Nabila Ali also pointed out that we need to work on our primary and secondary education to have a good lot to enter into the midwifery services. I believe there's a comment from Ms. Fozia from the Nursing Council. So,
Thank you very much. Dr. Azra, मैं आपसे सिर्फ थोड़ा सा ये कहना चाहूंगी कि being a gynecologist, आप लोग कितनी अपॉर्चुनिटी हमारे कम्युनिटी मिडवाइफ्स को फॉर ट्रेनिंग पर्पसेस देते हैं, क्योंकि चंद मेरे ख्याल में अगर few of gynecologists give opportunity for midwives for practicing in labor room, or तो ये थोड़ा सा आप इसको वो कर लें कि जब हम किसी को सिखाएंगे नहीं तो वो कैसे सीखेगा. तो ये आप लोगों की भी रिस्पॉन्सिबिलिटी बनती है, और इससे कि
इवन देन कि पाकिस्तान नर्सिंग काउंसिल ने एक टाइम पे एक लेटर भी इशू किया था कि गायनेकोलॉजिस्ट और एटलीस्ट 25 नॉर्मल डिलीवरीज तो हमारे स्टूडेंट्स करें। तो आप लोगों का भी इसमें मैं आपसे एक रिक्वेस्ट करती हूँ ऑन द प्लेटफॉर्म ऑफ HSA कॉन्फ्रेंस कि हमारे स्टूडेंट्स को भी अपॉर्चुनिटी दी जाए। और दूसरा जो आपने बात की है कि बेसिक एजुकेशन इनकी वो नहीं किया कि अब जो हम क्योंकि आप देखें वर्ल्ड के अंदर जो मिडिफरी है वो या तो 4 ईयर की है या 3 ईयर की है, तो हम 2 ईयर की कर रहे हैं, 2 ईयर और 1 ईयर की है। तो इसलिए इसको हम काउंसिल ने एटपार लाने के लिए हमने इसका जो बेसिक अब मिनिमम लेवल जो रखा है, प्री रिक्विजिट्स जो हैं वो है FSC आफ्टर 12 ईयर ऑफ स्कूलिंग। तो इंशाल्लाह हम इसको भी इम्प्रूव करेंगे। और अभी तो जो हमारे ऑलरेडी एग्जिस्ट कर रहे हैं जो कम्युनिटी मिडवाइफ्स वो ऑलरेडी वर्क कर रहे हैं, उन्हीं की वजह से जो थोड़ा बहुत हमने अचीव किया है मैटरनल मोर्टेलिटी और उसको रिड्यूस करने में, तो उनका भी पार्ट है। तो मैं आपसे यही रिक्वेस्ट करूंगी कि हमारे बच्चों को एटलीस्ट क्लिनिकल प्लेसमेंट पे जरूर अपॉर्चुनिटी दीजिए।
Thank you, Ms. Fozia. और इस बात पे I will request Professor Zohra for her comments because Professor Zohra has been, I would say, one of the champions in medical colleges and in especially in the terms of nursing and midwifery education. She's herself the head of obstetrics and gynecology department, and she has her faculty from the nursing college is right now in PIMS undergoing a training of trainers, a clinical tutors training for teaching the midwifery field. So Professor Zohra, if you can.
Thank you very much,
Thank you.
Dr. Mariam, for this opportunity. Madam, I will just respond to your comment. Yeah, no doubt, it's our responsibility to train your nurses in our hospitals. But I will also request to Pakistan Nursing Council that आपके जो college recognized हैं, make it compulsory. Like in the nursing, it's just like the curriculum. You just make a small component for assessment of their obstetrics hands-on training. जब वो curriculum का हिस्सा होगा ना, तो obviously they will work there and then they will be assessed and judged there, so that जो ये challenge है ना कि hands-on उन्हें opportunity नहीं मिलती, तो मैडम वो पूरी हो जाएगी। जी जी मैडम, उसमें अगर आप
के बेसिस पे बना हुआ है,
अगर उसमें आप हैंड्स ऑन का कर देना थोड़ा सा कंपोनेंट, जैसे हमारे टॉक स्टेशंस होते हैं, ठीक है, दैट्स हैंड्स ऑन ट्रेनिंग कि हमने फोर्सअप अप्लाई करने हैं, वैक्यूम करने हैं, न्यू रेस्ट्रिक्शन, जस्ट इफ यू कैन पुट, आई डोंट नो हाउ इट्स इजी और इट्स डिफिकल्ट, हैंड्स ऑन प्रैक्टिकल असेसमेंट ड्यूरिंग एग्जाम्स कर दें, दैट विल बी आवर प्राइम रिस्पॉन्सिबिलिटी कि हमने उन नर्सेज को डेफिनेटली हैंड्स ऑन करवाना है।
ओके, thank you so much.
Thank you. And I'll take just one last comment from Professor Dr. Shahana Uruj Kazmi. She's the Vice Chancellor, Women University, Sawabi. And then we'll have the shield distribution and group photo. Thank you.
Thank you so much for giving me an opportunity. One suggestion for Dr. Azra. She mentioned about the level of education that's very weak in the schools and colleges, etc. But most of the girls would like to be in the healthcare facility in some form or the other. In our university, we have the allied health sciences and we have health informatics and DMS, diagnostic medical sonography. I'm sure lots of girls in Swabi, which is a very remote area, would like to go into this midwifery thing, maybe a 2 years course or maybe a 4 years course. But sometimes, the parents and even the relatives don't like their girls to take up this. This is a very important profession, but because of the name, they don't want their girls to be called as BS in midwifery or something like that. Is it possible that the Nursing Council may change the title of this degree? There'll be lots of girls who would be willing to come, and very highly educated girls. You have very smart girls. I'm sure at Women University Sawabi, we would like to start this program right away. But maybe changing the name will really help. They don't want their girls to be called midwives. Thank you so much.
Dr. Saiba, the stigma is not the name, because International Confederation of Midwives is International Confederation of Midwives. They are much stronger than the International Confederation of Nurses. Both these senior professors have worked in UK, in Europe, where the midwife decides the outcome for the woman in labor. They are not ashamed to be called midwives. The problem in Pakistan is that the Urdu dictionary says midwife is dai, and the dai connotation has been taken very negatively. That is one of the things which Mrs. Imtiaz Kamal had been working on for a very long time and advocating as well. And we've also proposed this to the Nursing Council, to the ministry. They're with us on it. We are waiting to get the provinces on board for us to, in Iran, in Saudi Arabia, and in other countries adjoining those in the Middle East, a midwife is called an akila. That is what we have proposed for Pakistan as well, because the problem is the midwife Urdu dictionary, it says dai. And dai has become a negative connotation, which is just wrong. I mean, so instead of changing the name, we need to be advocates to improve the image. So it's a good point, but that's the situation. We shouldn't change the name. We need to advocate to improve the image.
I
So
just want to get small point. Just about the merit, madam, can you believe it? Like in Punjab, because of all the changes and efforts of the Pakistan Nursing Council, the closing merit of nurses is more than 94%. It's 1056. And the boys, the first session, जो पाकिस्तान का पहला मेल नर्सिंग कॉलेज पब्लिक सेक्टर का है, वो हमारी यूनिवर्सिटी ने फातिमा जिन्ना के साथ एफिलिएटेड है, लास्ट ईयर स्टार्ट हुआ है, उसका अपना जी क्लोजिंग मेरिट 95% गया है. FSC, they are really the gems now. It's our responsibility of the and it's the system responsibility कि जो स्टूडेंट प्री मेडिकल में 95% लेके आए हैं, हम उसको बना क्या रहे हैं. Now it's our responsibility.
And thank you to the people who stayed here. I mean, a lot of people moved out, and I thank you for your for bearing with us. I request my guest of honor to please step forward for shield presentation to Ms. Fawzia Mushtaq and to Dr. Ghulam Qazi. And while we do this, get ready in position with the photographer and all. I really do want to thank my support team, Ms. Aisha Naeem, Ms. Khizra Dar. There was one boy as well, I think Abdullah or Abdul Rahman, Abdullah, Zishan and Abdullah and Midhat. So they were the ones who gathered everyone, prepared all of these things, and I just came here and talked. So please, a round of applause for them. Thank you. They actually annoyed everyone so much that they said, look, we'll come and we'll show you our faces. So, and I would like to thank the support of Mr. Rizwan from UNFPA, who's our collaborator in this conference. Thank you very much. So thank you, Ms. Fawzia, for your contribution, for your support, and we have a small token of your for your participation. Ms. Fawzia Mushtaq, the Registrar for Nursing Council. Can we have we've taken the photograph, so please join. Dr. Qazi, if you can also please join, we have a small shield for you as well. No, sir, side please. Shield, baby. Madam, Dr. Qazi. No, we'll have a group photograph, then I'll join as well. So thank you so much, Ji. Thank you for having your support. And maybe we can have a group photo. So please, I'll just.
हो गया पूरा. बाजी हो गया. ये नेक्स्ट बस खत्म। Excellent presentation, excellent skill. एक ये भी बढ़िया बोले।
नहीं, शाम पे बैठ
हमारे पास उनके लिए कुछ कुछ चीजें है अभी नहीं हम कह रही तो बाकी तो आगे क्वेश्चन हो रहा है नाम तक शुरू से आगे क्वेश्चन करो उसका भी चाहिए बाकी तो इधर ही नाम लेकिन वैसे मैं बता रहा हूँ लेकिन आप मुझे कंफर्म कर दो ज़्यादा बेहतर नहीं। हाँ अचानक एक चीज बराबर बैठे ये हमारा सेट नहीं सही है सिंपल होता है तो फायदा हाँ भी बंद कर ये भी बंद करें कैमरे बंद करें हाँ उधर अंदर एसी में देखें थोड़ी देर करें
ये आप यूएस में पता ना यूएस में बहुत धूम होती है इवेंट पे ना
सिस्टम उतार
बाकी इधर ही लगे नहीं केबल शेबल बस आप अपना लैपटॉप शाम को मैं लाइव सुनते चलना है ना रूम ही सामने को
ग्राउंड फ्लोर वाला लेक्चर और कितना ऊपर ये पूरी मतलब पास में है ना